Hi guys, welcome to part 3 of our high yield neuro review. In this video, we'll be discussing neurological disorders along with the pharmacological treatment. So let's get started. This is going to be a slightly longer video, so we'll try to go a little faster. Okay, so we're going to start with migraines, and so take a minute, pause, and then unpause when you're ready. So thunderclap headache, this is associated with subarachnoid hemorrhage. It's usually the worst headache of your life. Number 2, headache with fever, stiff neck, positive Kernig's and Brzezinski sign. This is your classical meningitis. Number 3, hypertension, papilledema, vomiting and confusion. All of these are signs of raised intracranial pressure. So if someone comes in with a headache, please look at their retina, do a fundoscopy. Okay, trigeminal neuralgia, the triggers can be chewing, brushing teeth, touching face. You should do an MRI of the posterior fossa, because usually the impingement is in the you can see it in the, I believe it's the superior cerebellar artery that impinges on the trigeminal neuralgia. So posterior fossa MRI for diagnosis. Cluster headache is our debilitating pain, suicidal pain for about 5 minutes and goes on to about 2 hours, or anywhere between 5 minutes to 2 hours. And treatment, you give them 100% oxygen for 15 minutes. And then tension headache is your bilateral, non-pulsating, mild to moderate headache, usually because of stress. It is a diagnosis of exclusion. You want to make sure you've ruled out everything else before you give this diagnosis. Okay, and obviously there are migraines, but I wanted to get to some other things in here, but remember there's migraines. Okay, so drugs for headache and specifically for migraines, I'd say in this one. So unpause when you're ready. So your triptans and your ergots, okay, they are, again, so both of them you can see are used no more than 2 doses per week or 10 doses per month. Both triptans and ergots are only given once the migraine has started. Okay, these are not prophylaxis. These are once the migraine has started, and that's the dosage quantity. And also they are both agonists at serotonin receptors. Triptans are selective 5-HT1B 1D agonists. There's a mnemonic called one bad headache. So BAD, like B, and 1B and 1D agonist. Okay, one bad headache. That's triptans. And ergots are they act on more receptors, so you tend to get more adverse effects. So they act on alpha 5-HT dopamine agonists. Sumatriptans are pregnancy category C, so they are okay to use in pregnancy, whereas ergots are category X, so you should never give ergot to a pregnant woman. It has oxytocin-like action, okay, and you won't be able to sustain the pregnancy. Iranomab is a monoclonal antibody that binds and blocks the CGRP receptors, which are involved in the pathophysiology of migraines, and this can be used as a prophylaxis. So this is like a once a month, I believe, and it helps with preventing migraines. Okay, moving on. So moving on to traumatic brain injury, raised intracranial pressure, cerebral edema, and pause and then unpause when you're ready. Okay, so no loss of consciousness, ruptured or bridging veins. This is your, so ruptured off the bridging veins, sorry about that. This is your subdural hematoma. This is mostly seen in older patients who have falls. So subdural hematoma, you can see a crescent, crescent-like, crescent on CT can cross suture lines but cannot cross midline. Number 2, caused by the shearing stress experienced by the brain during acceleration or deacceleration. This is your diffuse axonal injury, the shearing stress because of acceleration or deacceleration. Okay, it can be mild concussion, severe, a neurodeficit, or even coma. Number 3, transient loss of consciousness, and you have the stock and die syndrome. Okay, this is a classical epidural hematoma. Okay, this is classic epidural with the talk and die. And this is usually the middle meningeal artery. You have these lucid intervals, you get a lens shape. So I believe this looks kind of like a lens shape here. And these can cross suture lines, can cross midline. Okay. And I guess they can cross midline, no, not cross suture lines. Number 4, patient presents with loss of lower limb motor function. So you want to remember motor function. If you remember the homunculus, your limbs are more medial, right? Your limbs are where your cingulate cortex is. In the homunculus, it's more medial, and it gets blood supply from the ACA. So if there's a loss of lower limb motor function, you want to think of a cingulate or subfalcine herniation up here. So if you remember this homunculus, you remember the feet were here, right? And this also compresses the ACA. Number 5, can cause a cardiorespiratory arrest. So this is where your cardiac and resp centers are. So this is all down here in the medulla. So this is a tonsillar herniation, which can compress the medulla. And patient presents with pupil dilation, ptosis, down and out eye. So basically what you're seeing is cranial nerve 3 deficits. So the kind of herniation that would affect cranial nerve 3 would be an uncal or a transtentorial herniation, which happens right here, sort of in the midbrain region. Okay, so transtentorial uncal herniation right here. What you can also see is cerebral peduncle is compressed. You see this thing called a Kinhohan notch. You can see ipsilateral limb weakness, which can eventually also become contralateral. So don't get stuck up on the ipsi versus contra. You can really see both with this. As long as you can remember cranial nerve 3 deficits, I think it's easy to identify the uncal herniation. And something you see with uncal herniation is direct hemorrhages from the tearing of the basilar artery, okay, in the midbrain. So direct hemorrhage. Okay, moving on. So brainstem, I believe, and spinal cord injuries. So pause and unpause when you're ready. Lesion in pons, the pupils will stay reactive, right? There's no cranial nerve 3 nuclei in the pons, so there's nothing to worry about. Pupils are reactive. It's not affecting the pupils in any way. And cluster breathing is classical of lesion in pons. Lesion in midbrain, now midbrain has cranial nerve 3 nuclei, so pupils will not be reactive, and hyperventilation is what you see if there's a lesion in the midbrain. It has to do with the different respiratory centers throughout the brainstem. Syringomyelia, they are needle-like cysts in the spinal cord, usually in the upper cervical region, and what we see is option F here. So we see a person presents with loss of pain and touch in arms and weakness in shoulder and neck muscles. So it's going to start with the spinothalamic tract, because the spinothalamic tract is what crosses right around the central canal. And as the cyst gets bigger, it will start to affect your dorsal columns and also the corticospinal tracts. So starts out with loss of nociceptive information, but eventually you see loss of even the good touch and motor, so weakness in the muscles. Okay, number 4 is Brown-Séquard. Brown-Séquard is the hemisection of the spinal cord. Half of the spinal cord is blown away, and you can see it's ipsilateral motor and touch and contralateral pain loss. Now, conus medullaris and conus equina. Conus medullaris is bilateral pain in usually going down the legs. Cauda equina is mostly asymmetric. I apologize. Conus medullaris is bilateral, does not radiate down the leg. Cauda equina is asymmetric and does radiate down the leg. The other things are usually pretty much the same, that you have perianal numbness in both, incontinence, impotence in both of them. It really has to do with the bilateral versus the asymmetric and radiation down the leg. So cauda equina, asymmetric, radiates down the leg. Okay, moving on. This is just a picture to remind you of the nuclei. So 3, 4, 6, and 12 midline, and then you can see the ones that are more lateral. Right, so if there's a lateral pontine syndrome, just by knowing what nuclei are there, you can tell me that there's going to be facial expression muscle deficits, there will be some hearing problems, there will be some mastication muscle deficits, touch, non-nociceptive information coming from the face deficit. So just by knowing where you are, you can really eliminate your answer choices. Okay, moving on to seizures. So pause and then unpause when you're ready. A simple seizure, no loss of consciousness, usually very short. If there is motor involvement, we call it a Jacksonian or a Marchick seizure. A complex seizure, we have aura with automatism. Automatism is like lip smacking, movement, etc. You have transient loss of consciousness in a complex seizure, bizarre symptoms depending on where they originate in the brain, and these can become generalized secondary. Okay, so they can start in one place, but they can progress to generalized. Okay, number 3, absence seizures. These look like the child may be daydreaming. They just blank out for like a couple seconds, and the classic what we see on EEG are 3 per second generalized spike plus slow wave complexes. Okay, tonic-clonic seizure. This is no aura. You have extension of extremities, which is the tonic, and then rhythmic movement and post-ictal drowsiness and confusion. So rhythmic movement comes the clonic. So you have tonic and then clonic followed by it. And then last is status epilepticus. This is a prolonged seizure. Usually it's a prolonged generalized or tonic-clonic seizure, and it can be all the way up to 30 minutes. You can have brain damage, loss of hippocampal cells, cyanosis, and death. Okay, there's a lot of risks associated with seizures. People bite on their tongue. They might be bleeding from their mouth. Okay, and for status epilepticus, it's an acute condition. You usually see this in the emergency. How do you treat it? Benzos. How do you treat everything else? Other anti-seizure drugs. But how do you treat something super acute? Benzos is the choice of drug. And I think we will discuss that. This is just a classification chart if you need extra help. So this is our drugs for our seizures. You can pause and unpause when you're ready. Okay, so our broad spectrum drugs are valproic acid, lamotrigine, and levetiracetam. We can pretty much use these for all types of seizures. Specifically, lamotrigine, levetiracetam, they are newer drugs, so they are safer drugs, so we can use them in pregnancy. But you would avoid valproic acid. First choice for absence seizures, this is your ethosuximide, use-dependent block of sodium channel. These are, that's the mechanism of action. So these are your carbamazepine, oxcarbazepine, phenytoin, and lamotrigine. Unique mechanism of action, they bind synaptic vesicle glycoprotein 2A to prevent glutamate release. So who has this unique mechanism of action? That's levetiracetam. Multiple mechanism of actions, that's topiramate and valproic acid. Topiramate is AMPA, acts on sodium channels, increases GABA. So the whole idea for seizures is you want to decrease the excitation, so you want to block AMPA, you want to antagonize AMPA, you want to increase inhibition, you want to turn on all the GABA receptors, and you might also want to block the T-type calcium channels in the thalamus. So you can see topiramate does AMPA antagonism and prolongs inactive sodium channel and also increases GABA. Valproic acid, again, inhibits the voltage-gated sodium channel, decreasing excitation. It also inhibits T-type calcium channels in the thalamus, which is our number 3, mechanism that we want, and increases GABA, so increases inhibition. So valproic acid pretty much does all 3 of these things. That's why it's a very broad spectrum drug. Okay, and number 6 is inhibits presynaptic NPLQ calcium channels. And this drug is our gabapentin. Okay, this is a narrow spectrum drug, and it's adjunct for focal seizures. We don't really use it by itself for seizures, but it's like an adjunct, and it's really mostly used for neuropathic pain and post-herpetic pain. Okay. All right, so moving on to, oh, there we go, cerebrovascular diseases. Okay, so take a minute and then unpause when you're ready. So what's the abnormality that you see here, associated with which pathology? This is, I apologize for how the letters came out here. This is your subarachnoid hemorrhage due to arterial venous malformation. So what you can see here, this like entangled, really thick, big arteries and veins. This is an arterial venous malformation that you're seeing here. And this can rupture very easily and can lead to a subarachnoid hemorrhage. Okay, so that's this option here. Some other causes of subarachnoid hemorrhage can be Charcot-Bouchard aneurysms, cerebral amyloid, and Berry aneurysms. And your findings are going to be abrupt onset, thunderclap headache, and nausea and vomiting. Okay, number 2, a 55-year-old woman presents to the ED after developing slurred speech approximately 2 hours ago. When she arrived, her symptoms gradually resolved, and CT head without contrast and CT angiography were unremarkable. So she had stroke-like symptoms, but then she automatically gradually resolved, and nothing was shown on the CT, or even if you do an MRI, you're not going to see anything on MRI. That's a TIA, that's a transient ischemic attack, that's a transient stroke. The thing with transient strokes is they can progress to a full-blown stroke, so you do want to monitor these patients. However, that particular stroke is going to be benign and won't leave any deficits. Number 3, what kind of pathology is shown here? What you see here is that little tiny kind of white dot. That's a lacunar infarct. Okay, and usually lacunar infarcts are associated with the lenticulostriate arteries, okay, which are branches of the middle cerebral artery, and these are the ones that are most commonly affected in a lacunar infarct. Okay, so cerebrovascular disease 2. Which day after infarct do you expect to see this feature? So pause and then unpause when you're ready. Pick A, this is day 1, this is your red neurons. Pick B is your lots of neutrophils, so this is your day 2. Picture C is you see mononuclear infiltrates instead, and then pick, which is day 3 to 5. And by the end of week 1, you should see your foamy macrophages. Okay, so that is, that's your answers. Cerebral vascular diseases. When would you see hemorrhagic mammillary bodies? This is your Wernicke's encephalopathy. And when would you see laminar necrosis with parasagittal necrosis and lacunar infarcts? This is global cerebral ischemia. Okay, what are some most common adverse effects of alteplase? Hemorrhage and due to the lysis of fibrin and plugs, and this can cause systemic lytic phase. So you want to first always get a CT and rule out that it's not a hemorrhagic stroke, because if it's a hemorrhagic stroke and you give them TPA, you're going to kill them. What is tenecteplase FDA approved for myocardial infarction? What is nimodipine used for? Cerebral vasospasm. Okay. So moving on to hippocampus, guys, neurodegenerative diseases. So pause and then unpause when you're ready. So Alzheimer's disease, this is a progressive decline in memory and learning. And what you see here are these 4 things. Please remember these 4 things. You see hyperphosphorylated tau, which are which give you neurofibrillary tangles. You see mutated beta amyloid APP gene on chromosome 21, which gives you the neurotic plaques. You see presenilins 1 and 2 and ApoE4 protein. Lewy body disease, this is associated with late-stage Parkinson's. You can think of it as hallucinations, right? So Lewy hallucinations. So what you do see hallucinations in Lewy body disease. And what you see in Lewy body disease is misfolded alpha-synuclein. They're called Lewy bodies or neurites. Okay, number 3 is frontotemporal lobe dementia, FTLD. Learning and memory is spared. However, it is a more behavioral issue. It's behavioral disinhibitions. They start to say really, inappropriate speech and social cognition. Okay, so this is what you see is mutated tau. You see a mutated TDP43, and you see frontotemporal lobe atrophy specifically. You could also see PIC bodies if this was PIC disease. And then Wernicke-Korsakoff syndrome, your mnemonic is Kong, confusion, ophthalmoplegia, nystagmus, gait ataxia, and you see the atrophy of mammillary bodies and the dorsomedial thalamus specifically. Okay, so that's NDDs. What are some drugs for Alzheimer's? So pause and unpause when you're ready. The treatment for Alzheimer's really is you want to increase acetylcholine and you want to antagonize NMDA. So to increase acetylcholine, you can use cholinesterase inhibitors like your stigmines and donepezil. For cholinesterase inhibitors, you have to start in early to mid disease. These are not disease modifying. And there's a lot of drug-drug interactions with these, and you can read this. And you also do need antidotes in case there's an overdose. Okay, and if there is a lot of adverse effects from cholinesterase inhibitors, those symptoms, we call them the dumbbells, right? You get the diarrhea, and I believe that's urine incontinence. Okay. Next is NMDA antagonist. This is your memantine. And memantine, it has to start it in moderate to severe disease. And it's actually potentially disease modifying. Okay, so it's a good drug, but we don't really start it until moderate to severe disease. Okay, moving on to some infections. All right, so increased lymphocytes, high protein, normal glucose. This is your Lyme's disease. Okay, so this is your Lyme disease, and you can read here. It's deer tick, erythema migrans. Okay, neonates, sepsis, meningitis, and gram-positive mononuclear cells in CSF. Okay, because it's a neonate, and we know neonatal meningitis, what's the most common infection? It's listeria. Okay, neonate develops sepsis and meningitis, but this time it's gram-positive polymorphonuclei. This will be strep A galactiae. Okay, so if it's mononuclear cells, it's listeria, because listeria is an intracellular bacteria, so you need your T cells to help you. But with strep A galactiae, you need your neutrophils to help you. Okay, acquired from corneal transplant, leads to ataxia, dementia. This is your classic prion disease. They're super resistant to denaturation, and you see a lot of neuronal damage. Patient went swimming in a freshwater lake and started developing symptoms of meningoencephalitis. So basically something you got from a lake. This is your Naegleria fowleri. It's a trophozoite protozoa and gets in through the cribriform plate, gets to the brain in coma and death. Increased lymphocytes, high proteins, and low glucose, and an increased opening pressure positive on an India ink stain. This has to be your cryptococcal meningitis. If you see India ink, that's almost always cryptococcus. So Cryptococcus neoformans, this comes from pigeon droppings in chronic course of this disease. Okay. So viral infections, you can pause and unpause when you're ready. So echovirus, this is your fecal oral transmission seen in younger patients. It's a GI route, like we said, fecal oral transmission. Second viremia can spread to CNS in children, and signs of meningitis and encephalitis. West Nile virus or West Nile infection, these are spread via mosquito bites. You can have bird hosts, and they cause a lot of weakness. Tetanus is the rigid spasm, the lockjaw, the the thoughtness, or so the lockjaw or the bended. Polio is rabies are option C. We can use two forms of the vaccine. We can use the Salk or the Sabin vaccine. The Salk is the inactivated vaccine. Sabin is the live attenuated vaccine. Rabies spreads by dog bites, option D, and you need both human IG and human diploid cell vaccine to treat. Okay, it enters PNS, it does that retrograde movement up the neuron and replicates in the dorsal root ganglion. Okay, and option 6, progressive multifocal leukoencephalopathy. This is seen with our JC virus. Okay, moving on. So moving on to movement disorders, you can pause and unpause when you're ready. Parkinson's, we lose the direct pathway. The substantia nigra pars compacta cannot signal to the striatum. Okay, so that's your D1 direct pathway. Parkinson's, we also see neuronal apoptosis from oxidative stress, inflammation, and mitochondrial injury. And don't forget alpha-synuclein misfolding. And we also see bradykinesia, tremor, and muscular rigidity in Parkinson's. In Huntington's, we see loss of the indirect pathway. So we see striatum D2, or which is unable to signal to globus pallidus externa. Okay, so we get too much movement. And Huntington's, we have polyglutamine repeats on chromosome 4. They have to be more than 34. There's anticipation. The child always gets more repeats and gets the disease earlier, usually gets it earlier than the parent. And histology, you're going to see atrophy of the caudate. So this is what normal looks like on the right. But if you see on the left, the lateral ventricles look bigger because the caudate is actually getting atrophied from the sides. So that's the atrophy of caudate. You can see some Lewy body reactive gliosis from GFAP accumulation. And you also see chorea, dementia, and death as the signs of Huntington's. Okay, moving on. So some other hyperkinetic disorders. So pause and unpause when you're ready. You have side-enhanced chorea. This occurs during or post a group A strep infection, or rheumatic fever. And there is a cross-reactivity between antibodies to group A strep. So you see chorea, emotional lability, and hypotonia. Chorea gravidarum E is during second trimester and usually to females who have a history of side-enhanced chorea. So if they got, if they had rheumatic fever as a child and they had side-enhanced chorea, when they get pregnant in the future, and during the second trimester, they will have chorea gravidarum. Tardive dyskinesia, like we discussed this before earlier with our antipsychotics, this is the more prolonged or chronic adverse effect of antipsychotics. We see movement that mostly affects tongue, jaws, lip, face, hand, and trunk. Essential tremor, they're bilateral, mostly upper extremities, and they improve with alcohol. That's the really cool thing. There's no neuroscience, it's just the tremor. Wilson's disease is option A. We have necrosis and cavitation of the basal ganglia and this is due to the accumulation of copper. So you're going to see high free copper in the body, and you're going to see low ceruloplasmin on labs. And then dystonia are like muscle spasms. You treat this with usually Botox. You can have dystonia of the neck, in the eye, in the limbs, or the larynx, like specific dystonias. For example, if you get it in the limbs, like in the wrist, let's say, it's the writer's cramp, right? Okay. This is a little summary sheet for drugs for Parkinson's. This is what normally we see happens when we process dopamine coming in from the gut. And so this is L-DOPA. You take L-DOPA. It crosses the blood-brain barrier. A lot of it gets metabolized peripherally, so only a little bit crosses the blood-brain barrier. Then it's processed to dopamine in the brain. Dopamine is metabolized. Dopamine releases reactive oxygen species. Dopamine can also go and activate the dopamine receptors in the substantia nigra pars compacta, which signals to the striatum. And here shows the drugs, and specifically the drugs and where they work and where they block, and how can we try to get more dopamine in the system, right? So one way of getting more dopamine into the brain is by blocking the peripheral metabolism. So you can block dopa decarboxylase using carbidopa, or you can block COMT using entacapone, and decreasing the peripheral metabolism, so you push more to the brain. Another thing you can do is with this dopamine, you can prevent metabolization of the dopamine to keep more dopamine available in the brain, and that's the drug silegiline. You can also use drugs that act like dopamine. They are dopamine agonists. They act like dopamine, they look like dopamine, and they can turn on the dopamine receptors in substantia nigra pars compacta. So that's your pramipexole and your ropinirole. And then you can also, decrease acetylcholine inhibition on the GABAergic neuron. So not inhibition, the acetylcholine activation of the GABAergic neuron. So you can block this using anti-acetylcholine drugs, which are benztropine or trihexyphenidyl. And if you can block the acetylcholine, you can actually get more dopamine to activate these neurons in the striatum. So those are like a general idea of your drugs. If you look in the slides and the notes, I have more information on each of these drugs. So drugs for Huntington's, again, I have just simply summarized these drugs for you. For the chorea, we use tetrabenazine. For the psychosis, we're going to use our antipsychotics. For depression, we can use fluoxetine, because there is lots of different symptoms and we have to treat each of the symptoms differently. Muscle weakness, so let's talk about this. So pause and then unpause when you're ready. ALS, this is, remember, when you lose both your upper motor and your lower motor neuron. Okay, so this is an SOD1 mutation, and it's a denervation atrophy of the muscles. Spinal muscular dystrophy is you have loss of anterior horn neurons. It's seen in infants. It's again a denervation atrophy, autosomal recessive mutation. Dermatomyositis is in the name derm, skin, myo, muscle. And dermatomyositis, you basically see inflammatory infiltrates in the perivascular space. Please don't confuse this with polymyositis. This is where we see inflammatory infiltrates inside the muscle, okay? Whereas in dermatomyositis, it's in the perivascular space. Guillain-Barré syndrome, this is usually an ascending paralysis, kind of like diabetic neuropathy, like that stocking glove pattern. However, it's different from diabetic neuropathy in the fact that it usually shows up after some kind of a viral infection. So history of resolved mycoplasma pneumoniae, for example, well, this is a bacterial infection, but some mycoplasma, or even after COVID, we're seeing a lot of Guillain-Barré. Lambert-Eaton syndrome, this is our option D. We have proximal muscle weakness, autonomic dysfunction, and reduced acetylcholine release at neuromuscular junction. It's sort of like myasthenia gravis, okay? But this is something we see associated with small cell lung carcinoma because of the paraneoplastic syndrome. And then limb-girdle, we basically see proximal muscle weakness with the winging shoulders, and this starts in late childhood. And you see dystrophin-associated proteins in your limb-girdle diseases. And obviously don't forget about myasthenia and multiple sclerosis. And here's again just a summary sheet for drugs for multiple sclerosis, everything in blue. And then you have some drugs for ALS. Again, ALS is a progressive condition. You can't really stop it. You just can extend survival time. Okay. Moving on to brain tumors. Take a minute to answer these and we'll discuss. So long cell, thin, slender processes, that sounds like hair-like, right? So pilocytic astrocytoma. You have astrocytes, Rosenthal fibers. Option number 2, you can see the tumor crosses the corpus callosum, and this is a glioblastoma. Okay, this is usually more in adults. Then a female patient with samoma bodies, spindle-shaped cells, and you see this on MRI. This is a meningioma. You can see that this tumor is growing out from the meninges. It's basically growing above the brain and it's pushing onto the brain. Okay, and this is one of the ex-tutors of Ross, Huda. It's her, really pretty picture of brain tumor, and you can always use this. Remember, anything below the tentorium is mostly seen in kids, and supratentorial tumors are mostly in adults. Okay, PNS tumors, so pause and unpause when you're ready. So cafe au lait spots, so all of these are seen in neurofibromatosis type 1. So that's cafe au lait spots. This is cutaneous neurofibromas, and these are leash nodules in the eyes. And this is a little table from UWorld that compares neurofibromatosis type 1 with type 2. So make sure you keep them separate. Okay, moving on to our local anesthetics. Okay, and the local anesthetics, they're actually, you don't have to match this table. I put them exactly in order, just so it's slightly less confusing. I know people usually struggle with this. So esters are the ones which have no I before gain. Okay, so like lidocaine has an I before gain, right? So that's gonna be an amide. So if you have an I before gain in the name, that's an amide. If there's no I, that's an ester. Okay, the esters are metabolized by pseudocholinesterases. The amides are metabolized by CYP enzymes. Number 3 is cocaine. Only local anesthetic that does its own vasoconstriction. Okay, all the other local anesthetics, we usually administer them with epinephrine for the vasoconstriction, but cocaine can do its own. Benzocaine is benzocaine or cocaine, they don't have an I before the cane, right? So what kind of anesthetics are these going to be? These are going to be esters. Okay, benzocaine, this is a topical drug. We use this for it can actually cause methemoglobinemia, the adverse effect of benzocaine, methemoglobinemia, and we can give methylene blue for reversal of methemoglobinemia. Prilocaine, this is used very commonly at the dentist's office. This can also cause methemoglobinemia. However, we do not give methylene blue for prilocaine. And lidocaine is a widely used local anesthetic. We can use it topically, spinal, epidural, peripheral, lots of different ways we can administer lidocaine. Okay. This is an example of how to calculate the local anesthetic, the calculation examples for how much drug. You can see an example here. So you have the drug that's ionized versus the drug that's not ionized. And the reason why that's important is because in order to cross the membrane, in order to get into the cell, the drug has to be non-ionized. But once it gets into the cell, we have to ionize the drug back up for it to go and block the sodium channels. Okay, so there's 2 formulas that you want to think of. There's the first formula of log ionized over unionized drug, pKa of the unionized minus pH of the body. And there's also ionized drug plus concentration plus unionized drug concentration equals 100. Okay, so this is an example here. If the body pH is 6.8, pKa is 8.2, and you plug in everything, you come to this equation here, but then you have to substitute the ionized drug. You can use the second equation here to kind of assume what ionized is going to be, and eventually calculate for both ionized and unionized percentages. Okay, so you're gonna have to use both of these formulas. Okay, moving on to our opioids. So take a minute and then unpause when you're ready. So what are the peripheral adverse effects that do not show tolerance? That's your meiosis and your constipation. What is the use of methyl naltrexone? This is opioid-induced constipation. Okay. Methyl naltrexone doesn't really cross into the brain, so it's good for the peripheral side effects. What is morphine contraindicated in? You do not want to give opioids to someone who's had a closed head injury, and also not for people with COPD because it causes respiratory depression. Okay, going into drugs of abuse. Okay, so pause and unpause when you're ready. Okay, so nicotine. Nicotine is a dependence receptor, is that one there, alpha 4 to beta 2, 3. Treatment is varenicline, or varenicline, can't say it. We don't use this with others. It's a partial agonist at the receptor, but we don't use this with any other drugs. If someone is on varenicline, you only give them that drug. You usually start it 1 to 4 weeks before the quit date. And bupropion is another drug that we talk about. This is the magic drug for ADHD, depression, and now smoking cessation, which you can start 1 to 2 weeks before quit date. And there's always nicotine gum as well. Alcohol is D. You have disulfiram reaction, which can be fatal with alcohol if during treatment, right? So during treatment, you can get this disulfiram reaction if the patient drinks alcohol. You can also use naltrexone. You can use acamprosate as different treatment options. When you withdraw alcohol, you have these different stages. You start with the tremor stage, then you go into a tonic-clonic seizure state, followed by hallucinations and altered mental status. Treatment for alcohol withdrawal, one of the, acute treatment can be benzos. Opioid, fentanyl. Fentanyl is very strong, full agonist. It's 3 milligrams, can be fatal. You're going to see all the classic pinpoint pupil, droopy eyelids, slurred speech, respiratory and cardiac depression, constipation, all the classic symptoms. What you want to treat this with is either methadone, which has a longer half-life, or you want to treat it with a partial agonist, buprenorphine, or you want to give them an antagonist, naltrexone. Now, be careful with an antagonist or a partial agonist because they can precipitate withdrawal. So you might want to consider starting with a longer half-life methadone and slowly tapering it down. Okay, option number 4, cannabis. Cannabis is your red eyes, dilated pupil, slow reaction time, increased appetite, you get the munchies, you have short-term memory loss, and can make you very paranoid. Actually, cannabis can trigger psychosis in some people. Stimulants is option G. You have euphoria, hypervigilance, anxiety, anger, agitation, dilated pupil, heart rate goes up, blood pressure goes up, confusion, arrhythmias, and even seizures. And at the end of, when it's coming down, where dopamine is being depleted, you get this like crash, and you feel like bugs are crawling on your skin with certain stimulants. Okay, and the next is hallucinogens, which are your psychobilins and LSD. So psychobilin, I believe, is what you see in the mushrooms, and LSD is what's commonly referred to as acid. So that is option E. There is no dopamine release, so really you never get any addiction dependence on withdrawal to these hallucinogens. And one thing we see with this is you lose track of time. LSD or acid can present very much like a stimulant, like we see in option G. The only difference might be that there is a loss of track of time. Okay, and this is what's called like a trip, like a good trip, bad trip. Okay, and hallucinogens like PCP and ketamine, these are a little bit different because they you can get addicted to them, and also you turn very hostile, violent. You get nystagmus, you have a higher heart rate, hypertension, almost superhuman like strength, and very long lasting psychosis with PCP and ketamine. So know the drugs of abuse. And then we're going to end with some sedative hypnotics and some Z drugs. Okay, so sedative hypnotics, they're anxiolytics, and increased frequency of chloride channel opening or GABA opening. That's your diazepam or your benzos. But increase the duration of your channel. This is going to be your phenobarbital or barbiturates. So benzos increase the frequency. Barbiturates increase the duration. Okay. Number 3, good for a patient that has liver disease. This is specifically going to be lorazepam or oxazepam because they don't need to be metabolized by CYP enzymes in the liver. They can go straight into the blood and then only have to be cleared out by the kidneys. So they completely skip the liver. Used for benzo reversal, you can use flumazenil, which is an antagonist. It's a benzo antagonist. Okay, and then used for generalized anxiety disorder. We already mentioned this one, buspirone. It's an anxiolytic. You have to wait for the buzz, right? So it takes about 2 weeks to kick in. And then 5-HT1A partial receptor agonist. Again, this is your buspirone. Okay. Moving on to hypnotics. These are our Z drugs used for jet lag and short half-life. This is going to be your triazolam. Triazolam is a short-acting benzo, okay? So you don't want to start anyone on benzos for any kind of chronic condition. It has to be for acute. So starting benzos just for like a few days just to treat jet lag, that's acceptable, okay? It won't cause any dependence. You do have to be careful though because it's a short-acting. It has a short half-life, so it can be addictive, so you do want to be careful with this drug. Number 2, binds to GABA receptors that contain alpha-1 subunit. This is all of your Z drugs or non-benzo drugs, which is your zolpidem, esopiclone, and zaleplon. Need 2 doses due to short half-life to maintain sleep. That's zaleplon. Zaleplon and zolpidem have very short half-life. So one of the good uses for them is if someone wakes up early, or if someone wakes up, let's say at 3 a.m. and they want to go back to sleep for like a couple more hours, they can take it once at night. It's a short half-life, so it won't put them down for a long time. They'll be able to wake up. So as long as you have 4 hours of sleep left, you can take zaleplon or zolpidem. And the only drug approved for long-term treatment of sleep disorder, that's esopiclone. Okay, so only one approved for long-term. So that's it. I know this was a long video, but you're gonna have the slides. So hopefully there are some notes on some slides. So just check the notes, and hopefully this was helpful. And if you have any questions, you can put them down in the chat box. I usually do reply to the comments. Okay, thank you guys. Good luck.